This week's presentation is on Chapter 7, Promoting Fine and Gross Motor and Adaptive Skills Development. The theories in our chapter account for genetic, experiential, and cultural factors. There are three main theories discussed. The neuromaturational theory is as the child grows and the central nervous system matures, skills unfold in a predictable hierarchical manner. Intervention within this theory promotes skills following a developmental sequence. The motor learning theory is based on the importance of practice for learning, retaining, and refining movements. Therapy in this theory is based on practice within meaningful contexts, such as in daily home and school routines. The sensory motor theory is based on the importance of sensory processing and collection of information from different sensory systems to the development of body awareness and learning more about their bodies and the environment. Therapy for this theory consists of providing opportunities for sensory experiences daily to promote motor planning and sequencing. Treatment models. There are four objectives of physical and occupational therapy. These are to promote active movement, to promote functional skills, to promote community integration, and to prevent impairment. Therapists use 5 different approaches to complete these objectives. The remedial approach is the most familiar approach. Its goal is to correct deficits that get in the way of typical motor development by identifying said deficits and resolving them by promoting age-appropriate and sensory motor abilities. The compensation approach is providing an alternative method, such as an assistive technology or adaptive equipment, when an impairment prevents the function or skill from being accomplished. They can help prevent further impairment as well as promote development. The promotion approach is a therapeutic interventions that are embedded in natural activities and routines to ensure the child's activities are beneficial, therapeutic, and functional. This is based on the developmentally appropriate practice guidelines that we studied in Chapter 1. The prevention approach is proper positioning or actions of a child with known disabilities in order to avoid developing secondary impairments or disabilities. The hostilic approach is a combination of all 4 of the others and is most often used by therapists. Many interventions are now based in daily routines and activities to promote generalization, which is the ability to use skills in a variety of situations. In activity and routine-based intervention, therapists, the family, and other team members work towards integrated outcomes and goals. Therapists use a variety of supports due to the complexity of some neuromotor dysfunctions. Some supports to therapy are assistive technology, such as a wheelchair or an adaptive keyboard, some adaptive equipment, such as cushions or pencil grips, or orthotics that are foot or ankle braces or splints. There are 3 types of service delivery models discussed in our chapter. Direct service delivery is intensive, specialized one-to-one therapy with strategies used to teach specific skills, introduce new skills, change detrimental behaviors, or increase sensory motor tolerance. This delivery often takes place in a clinic, a specially designed room in a child care or education program, or a separate space within a classroom. Recently, direct service delivery has been dropped for integrated programming, in which children receive individual services within an integrated environment of children with and without disabilities, such as an integrated classroom. Monitoring service delivery is composed of therapists designing activities to be provided in the setting, teaching professionals and providers specific methods for embedding therapy strategies into routines, observing the professionals and providers as they perform the strategies, giving feedback and guidance, adapting and updating strategies when necessary, and supervising the implementation of the therapy program, as well as taking on responsibility for documenting the child's performance. There are 3 significant benefits to this delivery. 1 is the amount of time a child is receiving benefits from a therapeutic strategy increases. 2 is the strategy has an increased opportunity to help with the generalization since it is within routine and natural activities. And 3rd, the strategy is implemented over time, giving continual reinforcement to target behaviors. Consultation delivery has 3 critical characteristics: regular interaction among team members, respect among team members for each other's skills, and the belief that the consultation will help the common overall goal of benefiting the child and his or her family. The ideal solution offers a variety of approaches and services that may change as the child's needs change. There are 3 parts to assessment practices. Screening is the first step in identifying infants, toddlers, and preschoolers who may need developmental support. 2 popular screening tools are both easy to use and reliable in identifying motor deficits and delays. The first is the Denver Developmental Screening Test. The second is Ages and Stages Questionnaires, or ASQs, which ask parents questions that are looked at later by professionals. Diagnosis is the second step to assessment practices. Tools comparing the child to others of the same age, determining the eligibility for services based on a set and standardized criteria, such as the developmental milestones of both motor and other developmental areas. A commonly used diagnostic tool is the Peabody Developmental Motor Scale, which assesses fine and gross motor skills from birth to 6 years. Some other tools include Bayley's Scales of Infant Development, Mullen Scales of Early Learning, and sensory profiles. All of these can take under an hour to administer and assess more than just one motor development. Program planning is the last step. Therapists must also help develop and assist in implementing individualized family service plans and individualized education programs. There are 3 kinds of assessment processes discussed in the chapter. The top-down approach assessment has general and specific statements of desired outcomes, or what the therapist would like to see. Using this approach, you can help determine what factors interfere with or promote the child's accomplishment of the outcomes. The routine-based assessment determines the child's capabilities within everyday activities and routines. It's useful for program planning because routines are meaningful to parents, caregivers, and teachers. The use of routine promotes the development of functional goals and identifies strategies that are practical, short, and non-disruptive to the rest of the routine, and shows how the child solves problems within the routine. Judgment-based assessment is fairly new. Information is gathered from those who observe the child on a regular basis, such as parents, teachers, and caregivers, and this provides a detailed description of the child's strengths and needs. We will now move on to characteristics of children with physical disabilities. Cerebral palsy is caused by multiple prenatal, neonatal, and postnatal causes that lead to anoxia or brain hemorrhaging. Characteristics of this disorder include disordered movement leading to atypical muscle tone, strength, and joint limitations. Conditions associated with this disorder include intellectual disabilities, which happen in between 50 to 67% with cerebral palsy, speech disorders, visual deficits, hearing impairment, seizures, and perceptual difficulties. Spina bifida is caused by embryonic neural tube defect of genetic and environmental causes. The characteristics of this disorder are varying degrees of lower body paralysis due to the protrusion of spinal cord through an opening in the vertebra. Associated conditions are hydrocephalus, or having liquid within the brain, bowel and bladder incontinence, loss of sensation, intellectual disabilities, and visual or perceptual difficulties. Down syndrome is caused by a chromosomal abnormality when a child has an extra chromosomal material. Some characteristics of this disorder include low muscle tone, flat nasal bridge, epicanthal folds of the eyes, small mouth, and low-set ears, which are common physical traits. Conditions associated with this are congenital heart defects, which takes place in 2/3 of the people with Down syndrome, hearing loss, which also takes place in 2/3, hypotonia, or low muscle tone, joint hyperextensivity, intestinal problems, respiratory infections, thyroid problems, and/or vertebral instability, and a majority also have a mild to moderate intellectual disability. Other conditions impacting neuromotor development include many that are not diagnosable but can still be eligible for services. Autism, which is becoming more and more prevalent, can cause delays in acquiring motor skills, dyspraxia, which is poor motor planning skills, low muscle tone, and sensory processing dysfunction, which is sensory defensiveness to sounds or touch. Our book describes 5 different therapeutic intervention strategies. The first is positioning. Children with severe motor impairments need to be positioned to promote independent functioning and symmetrical body alignment and prevent further disability. Therapists will show parents, educators, and caregivers how to position children to promote social interaction with peers and adults and to promote learning. Playing with people and objects can also have adaptations. Adaptations can be made to toys to make them more appropriate for children with atypical motor development to play with. Toys should be made physically, which means changing the position of the toy for better access to the child, and mechanically available, which is changing switches or mechanisms to promote independent use. Arranging creative movement in games that all children can partake in is another part of this. Promoting gross motor skills can be done through structuring activities that promote foundational motor skills, regardless of abilities or skill level. An example of this is a game like Animal Walk, pictured in the photo. When promoting fine motor development, you also want to focus on foundational skills that will help children with skills later, like tying shoes, cutting with scissors, and writing. Some examples of this are lacing and sewing, finger play, or tweezer time. You can also adapt curricula through collaboration of therapists and other professionals to fit the individual's needs. This can be done by arranging activities that have minimal movements to accomplish tasks, allowing and encouraging peer-to-peer support, and giving choices to allow children to pursue and explore their own interests. There are some curricula specifically developed to promote motor skills, as well as several books for motor activities appropriate for children with delays. Children with disabilities may require the help of therapists, both physical and occupational, when learning skills for daily living. Sometimes the tasks or the environment may require modifications as well. For feeding, sometimes atypical motor patterns caused by oral, motor, sensory, or feeding process may make feeding difficult. Some interventions you can take are proper positioning, finger feeding to promote self-feeding later, supportive chairs seated with family and/or classmates, hand-over-hand feeding, or independence promoting utensils. Some things to consider to improve oral motor functioning are to rule out medical complications that could influence feeding functions, collaborate with the family and team members to determine needs and develop a plan, and provide interventions considering all aspects of the child's needs. Here are some strategies for dressing. Be patient. Use loose-fitting clothing without fasteners to make it easier for independent dressing. Encourage easy fasten clothing such as snaps, large buttons, and Velcro, and work towards more difficult such as zippers, hooks, and small buttons. Sitting while dressing can help children with poor balance. Also, having the child put on 1 or 2 items at least before doing the rest, if the child is easily tired or dressing is too challenging for them, can be a good step for busy mornings. Creative cueing, like color coding, to differentiate back from front, left from right, or outside from inside for children with perceptual and spatial difficulties, is a good way to help when they get dressed. Also, shoes with Velcro fasteners, elastic shoelaces, or slip-on shoes are helpful when a child cannot tie their own shoes. Having adaptive skills for personal hygiene is also very important. Personal hygiene includes toileting, bathing, and oral care. Suggestions for compensating when a child lacks skills to perform or has difficulty with certain tasks includes bath chairs and benches for stability, armrests or raised seats for the toilet to help ease transfer to the seat or stability during the task, adapting the environment to make it physically accessible, like a step stool to the sink, or teaching children in wheelchairs how to manage doorways and getting around, a battery-operated toothbrush for children with joint limitations or weakness, or built-up handles on toothbrushes, hairbrushes, and more for children with weak grasp or movement limitations. That concludes my presentation on Chapter 7. Here are some questions to think about. You are providing services for a family of a 4-year-old child with a severe case of cerebral palsy. What approach to intervention would you take, and why? There is a child in your classroom that has some motor delays and struggles getting ready for recess every morning. List 3 strategies you can use to assist him with this task. And lastly, using routine-based intervention, give an example of the morning routine of a preschooler with motor dysfunction. Thank you for viewing my presentation, and I look forward to reading your responses.